talk about prostate disease and its impact upon men. Are very lucky tonight to have with us Dr. John Mulhall from Memorial Sloane Kettering, a renowned urology surgeon, and Melissa Hadley Barrett from Perth, Australia, who is the leader of the penile rehabilitation program, and Mike and Shirley Prescott, who have gone through prostate cancer rehab together, because it is a couple that goes that together. John, I'd like to, if you don't mind, I'd like to ask you to speak first. I'm interested in your perspective on one recent changes in the diagnosis and management of prostate cancer, and in particular its impact upon men's sexual health. Certainly, if you could touch light on some of the things that still remain in people's minds, which is, for example, the use of female hormones, and helping people differentiate between cryotherapy, the knife, and some of the other therapies, and then from there take us into the impact upon men's sexual health.
Yeah, so I think, can you see my screen?
I can.
Good. So I think that these are my disclosures, as I'm wont to describe. So first of all, I'm a penis doctor. I do sexual and reproductive medicine. I've done so for 28 years. I'm not an oncologist. I hold physicians of all kinds to very high standards, whether it be prostatectomists or radiation oncologists. I'm consumed with the truth and science, and I do speak quickly. And if you want to follow me on Twitter, this is my handle. It takes 50 years to get a wrong idea out of medicine and 100 years to get a right one into it. And I think the wrong one is your PSA is undetectable, Mr. Jones, and therefore you should be happy. When in fact there are plenty of men who have sexual problems and continence problems who are miserable after their surgery or their radiation or their hormone therapy. The advent of minimally invasive therapies such as IRE or photodynamic therapy or HIFU is very interesting, but I have to say we do not yet have a very good handle on the true impact of these therapies on long-term sexual function. What is clear is that if you have hemigland ablation, you will probably do better than if you have total gland ablation. And if you've total gland ablation, it appears from the literature that your erectile function outcomes are somewhat akin to men who have excellent bilateral nerve-sparing radical prostatectomy. But it's very early days yet. Now, I'm not talking about oncologic outcomes. I'm just talking about sexual function outcomes. There's nowhere in the prostate cancer journey, as Mike and Shirley, I'm sure, will tell you, where erectile dysfunction or sexual dysfunction in men is not a problem. Diagnosis, surveillance, definitive therapy, adjuvant, end of life, all of these phases are associated with sexual problems. And not just in a man, but we've recently published with Stacy Lowe from New York University that it has a significant negative impact on the sexual health of the female partners and their quality of life. The only sex-friendly prostate cancer management strategy is active surveillance. Any intervention is going to have a negative effect. There are a host of sexual dysfunctions that you see listed here, but we'll talk primarily about erectile dysfunction over the next few minutes or so. The cause of ED after radical prostatectomy, after radiation therapy, after hormone therapy is really pretty much the same pathway. Nerve injury, blood vessel damage, and then the final common pathway to men having permanent erectile dysfunction is smooth muscle changes. We say to a patient, or I say to a patient, that, think of your penis like your biceps, Mr. Jones, and what happens if you put your arm in a plaster cast for a year and you don't move it? It undergoes atrophy, right? Yes. The atrophy in the penis isn't really atrophy. It's collagenization, it's collagen deposition, and that's why it is irreversible. Erectile function preservation, if you're going to speak to a doctor, it's worthwhile trying to define what the planned degree of nerve sparing would be at prostatectomy. We know that baseline erectile function is important in predicting outcomes from prostatectomy and radiation. Patient age is relevant for prostatectomy, radiation, and hormone therapy patients. Physician experience, physician volume, medical conditions. So, for example, things like diabetes, obstructive sleep apnea, and very low levels of testosterone portend a very poor prognosis for recovery after any of the treatments for prostate cancer. So there is an argument to be made in those men with low or low intermediate prostate cancer to take some time off before intervention and modify diabetes control, treat the sleep apnea, and upregulate the testosterone levels. Duration of hormone therapy, it's certainly beyond 6 months. That's a very concerning duration. And there are many men who spend 2-3 years on hormone therapy, and that can have devastating consequences, particularly on the smooth muscle in the penis. So prostatectomy causes immediate erectile dysfunction. The low point is 3 months after surgery. It takes 18 to 24 months to have recovery. Only 20% of men get back to baseline, and this figure is very, very much lower in men who are over 60 years of age. Ejaculation, of course, all men do not ejaculate after radical prostatectomy. That's a truism, just impossible to ejaculate. After radiation, there's no clear evidence to suggest that one modality is better than the other, whether it's seeds or whether it's external beam or proton therapy. There's usually in men with good baseline function little effect in the first 12 months, and the nadir is somewhere between 3 and 5 years after completion of radiation therapy. So there's a slow negative effect on the penis. ED rates with prostatectomy versus radiation are about the same at 3 years, provided you're comparing radiation monotherapy and good nerve-sparing surgery. What's interesting is there are significant negative effects on ejaculation, albeit delayed after radiation, with 90% of men at 5 years having no ejaculation whatsoever. Hormone therapy is very problematic, as I alluded to earlier on, because it causes degeneration, collagenization of the smooth muscle, and it does so within a very short period of time. Certainly beyond 6 months, 6+ months, you start seeing degeneration of the muscle, and that degeneration leads to a condition called venous leak, where the valve mechanism inside the penis does not function properly. There's no ejaculation when you've no testosterone. There's no semen to be made. 90% of men on hormone therapy have no sex drive, and it's almost impossible to have an orgasm when you're on hormone therapy. So just some final parting messages, things that you can think about. We're in a state of obsessive oncocentricity, that oncologists are so focused in the prostate cancer space on PSA that they lose sight of things like incontinence and sexual dysfunction in a couple. You think that your treating clinician will tell you all you need to hear, when in fact the physician will tell you what they think you need to hear. So when you're speaking to a physician before treatment or after treatment, you need to go in with a list of questions that you want answered. Before committing to any treatment, whether it's surgery, radiation, or hormone therapy, think seriously about how important your future sex life is and communicate that to your physician. Understand what your treating physician means by erectile function, preservation, or recovery. Is that, I have great figures of erection recovery, is that when men are using penis injections, for example, or is it natural erections? And that definition varies in the medical literature. Get realistic expectations about the time frame for sexual function recovery and preservation. Remember, 18 to 24 months after prostatectomy and 3 to 5 years after radiation before men reach the low point, and then it plateaus. Beware physicians citing incredible figures for erectile function preservation and recovery. There's literature that suggests that 97% of men have erection function recovery after radical prostatectomy, and that just defies the laws of physics and physiology. Open versus robotic surgery, there is no proven difference whatsoever in sexual function outcomes, but the reality is that almost no surgeons in training, urologists in training, are getting exposed now to open prostatectomy and barely know how to do that operation because it's all robot-based. As I said, there's no clear difference in sexual function outcomes between different radiation modalities. And we're going to hear about penile rehabilitation. Don't be afraid to speak up and ask about penile rehabilitation. Is it offered? What does it entail? Etc. And if you need androgen deprivation therapy, ask your physician about survival benefit and for how long you will be testosterone efficient. Very, very important. Survival benefit. 6 months versus 24 months. Do I even need hormone therapy? Dr. Jones. Triple therapy, that is surgery, radiation, hormone therapy. I saw 150 triple therapy patients last year. It does not mean the end of your sex life. And then finally, I think that we should all, as physicians, clinicians, not focus solely on adding years to a man's life, but also paying attention to adding life to years. I'm a quality of life physician, and that's why I'm here tonight. And I think we'll have questions and answers later on. Thank you very much.
Thank you, John. I have several questions, but I'll save them. Melissa, one of the common complaints that I hear from at FirmTech from men who are using our device is after surgery, the doctors don't talk to them, and they end up being managed by nurse practitioners and PAs, and that's your area. It's a point of frustration for people because people would like to discuss things with the doctors. sometimes I feel that there's an inhibition on the part of the doctors themselves about talk about sexual issues. Let's hear your perspective. What do you feel is most valuable? What questions? John alluded earlier, stated people need to go to the doctors with a list of questions in mind that they should be asking their physicians. So I know you weren't prepared to answer that question, but what should people be asking? People don't know what they don't know. What should they be asking? And then afterwards, tell us about what you see that's new in rehab after surgery.
So I think the big thing that I've noticed in the 8.5, 9 years that I've been doing penile rehab and working with men with prostate cancer, post-prostate cancer treatment, is that I think the surgeons and the oncologists are becoming more open about talking about it, particularly in Australia. So, and I think it's important to understand that often I think that they do actually mention the fact that they're going to lose their sexual function and they need to do rehab, but it's involved in that initial conversation when they've first been given a cancer diagnosis. So we know that patients don't listen or take home or be able to, internalise everything they're told. So I think actually having your own agency and going, when you first get that diagnosis, going home and thinking to yourself, what are my important things later? Number one is usually get rid of the cancer. Number two is most men don't want to be incontinent. And number three is their sexual function, or sometimes sexual function is more important than any, and there can be a different order that they go in. But I think knowing that you're not going to get everything out of one practitioner is really important. Your GP is a jack of all trades and a master of none. Your surgeon is a surgeon and probably doesn't know as much about the other modalities as they do about surgery. And an radiation oncologist is the same. And I think it's very important when you're thinking about your sexual function to see someone who specialises in that area, and when you're thinking about your continence, to see a physiotherapist who specialises in pelvic health. So I think expecting to get all of your treatment and care from one practitioner is a little bit unrealistic for us as patients. And I think the big thing is that we need the surgeon or the oncologist or the diagnosing doctor to be aware that there are these facets to making sure someone has a good quality of life later, and will not be able to answer all of the questions or give people all of the treatment options for these things, but should be sending them in the right direction. So I think that's the most important. And then I think that people need to do their own reading and their own homework, and there's so much available now. And I know it's confusing on the internet because there's a lot of rubbish, but there is a lot of good information. So, I think if people know that they check people's qualifications, read, there is, simplified versions of the research that's coming out. So inform yourself. If you're a reader, read papers. If you're a watcher, watch videos. If you like to listen to podcasts. And I think getting real people's experience, and we're going to hear that soon from Mike and Shirley, is so important, because we all have to remember that research is wonderful, but research is often published quite a while, a few years after it's actually produced. And not only that, is that, research needs funding. So a lot of things, I think that we underestimate the real life experience of patients. And I also think the other thing is to think that after you've had prostate cancer treatment, your sex life isn't going to be the same, but it doesn't mean that your sex life can't still be really good. And I think people are often surprised to hear that a lot of my clients will say their sex life is better a year post-treatment than it was before, not because their function's better, but because they've talked about it, they've thought about it, their function wasn't that great before, and they hadn't realised it had gone downhill, and they've done things like use a penis pump, and they've learnt how to use injections, and they didn't even know they weren't having nocturnal erections, and they're using something like a FirmTech to measure that and actually understand how their body's working. So I think often it can be a distressing time having a prostate cancer diagnosis, but it can also be enlightening. It just is the way you look at it. Does that answer your question?
Yeah. So what to your mind should be the standard of care for interventions? Speaking about, and when should they be introduced? Speaking about pumps, PD-5 pills, testosterone, erection.
I think the first really important thing is that people should know what their baseline function is. So I think if you get diagnosed, in an ideal world, it would be amazing if every man that I saw pre-operative or pre-radiation I could send them home with a device such as the FirmTech ring, and I could say, let's have a look for the next 4 weeks of what's going on now. So we actually had a baseline data of what's happening, because then, and as John just described to us, that, your function's not going to be exactly the same. It is going to change, but let's have a goal that we would like to hopefully get back to pre-op function. And, I have actually seen in the last couple of years quite a lot of men that have got back to pre-op function, and I've seen quite a lot of other men who have had worse function pre and better after, because they've added in some adjunct therapies that have helped them along the way. So I think knowing what your pre-op function or your pre-radiation function is really important in an ideal world. And then knowing that, understanding what should be happening. A healthy penis should be having 3 to 5 erections a night, and that is going to stop for at least a period of time during surgery or after surgery or after any treatment. And as John said, you wouldn't stop exercising your bicep, you'd keep it going. Things just wither away when you don't using them. So, it's a no-brainer, and there isn't any definitive research about what the right regime is to use a penis pump. But, I just think it's a no-brainer that if you're supposed to be having 3 to 5 erections when you're in REM sleep every day, then let's replicate that so that we're replicating what happens in nature and we're keeping things moving. And so I'm a big advocate of knowing what your baseline is, using a penis pump. I always say 4 weeks post-surgery. And to be honest, there's no research to back that up. I just like to be 100% sure that the anastomosis between the urethra and the bladder is very well joined. And if they have radiation, I say as soon as they know that their nocturnal erections have gone, then it's important to start using a penis pump. So when you know things change, you need to start using one. I say 5 minutes a day, 3 times up and down. And I recommend 3 different types of pumps, one of which is the Bathmate. And I've got videos on all the 3 pumps that I recommend on my YouTube channel. So I think that they're really important. I love the Bathmate particularly because if you're leaking and you're incontinent in that initial post-surgery stage, then it's great to use that in the shower and not have to worry about the mess and wee and all of those things.
Just a couple of comments. When I invented the tech ring, I was thinking about erectile dysfunction. I really wasn't thinking about prostate care at all. I'm not a urologist nor an oncologist. But it's profoundly valuable to get a baseline, because right now the baselines are based upon subjective scoring questionnaires that are standard, and the variability with those is not scientific. So the tech ring data can make it objective beforehand. I can't speak yet as there's research that's going to be done soon. Admiral Sloane Kettering to assess the value of the tech ring. But I do know that we've had a couple of men who were recommended penile implants, but they had nocturnal erections, and they obviously chose not to have surgery because that would be unnecessary. And one of the things you can do with the tech ring is you can actually look at these modalities after prostate surgery and measure their impact. Are the PD-5 medications working? What's the right dose? If I'm pumping, am I also restoring my function as is reflected in nocturnal erections?
I think the other thing that I've been finding that really useful for is usually at about 12 months post-surgery, guys are getting sick of using their pump when I'm telling them to do that all the time. And they'll say to me, I think I might be getting nocturnal erections again, Melissa, but I'm not sure. And I don't know how many because they're asleep. And I'll say, well, why don't you try one of these and have a look? And if you know you're getting 3 decent nocturnal erections, then you don't need to worry about your pump. Put it in the cupboard for a while. So I think, nobody wants to be doing that every day for the rest of their life. So being able to just know what is going on in your own body is important. And also, I just think it all comes back to self-agency. Like if you're seeing improvement as time goes on, if you're waking up in the morning and I call the FirmTech ring your Fitbit for your dick, you're clicking on your phone and stuff's happening and you see you've had your workout, then you feel positive about that things are getting better. And I think the other really big thing is, I always say to the guys I see, try and cut back on alcohol, stop smoking, do exercise. And if they monitor, like I exercised today and I didn't drink any beer, and wow, I had 5 nocturnal erections last night, that's a positive reinforcement for doing things. And you don't have to be just worrying about your prostate and your or lack of prostate and your sexual health. We're also then improving people's lives and health in general. So I think there's a whole lot of benefit to that.
What do you see as the role in rehab of testosterone and supplements? Supplements meaning citrulline, L-arginine, nitric oxide pills, maca root, horny goatweed, etc.
Yeah. So look, I think there's a lot of snake oil salesmen out there selling a lot of rubbish, to be honest. So, and I've had men turn up in my clinic with bags full of supplements they've bought. I always prescribe tadalafil, low-dose tadalafil every day to improve blood flow to the area. And if people don't tolerate that, then a small dose of sildenafil. That said, there is some research available about using curcumin, so turmeric supplements to improve blood flow and reduce inflammation. So I think that's valuable, and it's certainly not going to do any harm. And L-arginine and L-carnitine, there's some research out there that shows that they help with nitrous oxide and blood flow. So I think the important thing here is not to think that there's a magic bullet, and that you can just do one thing, but if you can look at this whole situation holistically. So you're thinking about your mental health. There's, being intimate isn't all about having an erection. So there's so many other things we can do, and, thinking about your connection with your partner, and then also thinking about, if you want to take herbal supplements and they're not doing harm, go for it. Making sure you exercise, making sure you keep your weight down, making sure you use a penis pump. Like, it should be a whole holistic way that we look at it.
Well, one these men can do with the Kettering is become an N of one. And we have men who report to us that when they're taking supplements, they experience more nocturnal erections, and other men taking the very same supplements who have no benefit whatsoever. Pending larger studies, the ring does give people the opportunity to be their own research subject for any modality. Let's turn to Mike and Shirley, you have Mike. Why don't you tell us when you were diagnosed, the type of surgery that you had, and the journey you've been on to recovery.
Sure. And when Shirley wants to throw something in, she's sitting here more than welcome, and is probably more of she's a better spectator than anybody else could be. But I was diagnosed around May of 2022 and had the robotic surgery in July of 2022. So immediately after that, we were
with nerve sparing.
Yeah, with unilateral nerve sparing, one-sided nerve sparing. So shortly after that, we were notified about Melissa's podcast. And I think that going back to what Dr. John was saying, have clear, concise discussions with your doctor. And if your sex life is important to you, you had better speak up, because in this case we had, exactly, the first day. And in this case we had a very caring doctor who we could tell the surgeon right off was actually concerned for us. So having that psychological boost going in at least made us know that they cared. And shortly after that, after the surgery, everything was just like everything I had read, incontinence, lack of erections, sex life is just put at the docks for a while. And at the same time, one of the therapies was walking. And one thing I could do while I was walking was listen to podcasts. And I had never really listened to many podcasts ever, but we were made aware of Melissa's podcast. And what Dr. John was saying, that education is so important in finding information. And when you hear others, obviously it's cliche-ish, going through the same thing and hearing their journeys, hearing where they are, kind of gauging yourself, well, I'm not quite there yet, and then realizing that we're all completely different. There's not one soul out there that's going to recover at the same rate, some faster, some slower. But early on in the process, Melissa was kind enough to have Shirley and I on and podcast, and it helped us kind of explore our own lives. And the one thing I wanted to touch on just real quick that I told her was probably the most important thing I wanted to get out there was psychological damage in this case. If a guy has been having a normal sex life, if a couple's been having a good sex life and that is taken away, it does present psychological challenges. And in my case, it was the thoughts of suicide. Did I ever try to act on it? No, but did I think about it? Absolutely. So oddly enough, after our podcast, I think episode 141, you came on the podcast, Elliot, and Shirley and I were listening, and we were actually on a trip, and the term came out, a Fitbit for a dick. And I thought, how cool is that? You know, I'm in technology, and I thought, you know, I was reaching out for anything I could at that point. In our rehabilitation, we were still early. I think we were probably 6 months in. I even told Melissa, I said, hey, we were so excited that, at least I was greatly excited that I achieved a 60% natural erection, you know, with Shirley's excitement. And having the partner there, obviously is 100% of the process. Without that, there's not much reason to keep you going. So in that following podcast that we listened to, and you were talking about your device, I said, I've already spent $1,000 on cock rings that are much too big for me. I mean, you could put two of me in some of those. And so that didn't work out very well. Then we spent money on other devices, and a couple of them, you know, I wouldn't say work, but they were interesting. And we had never, you know, we were like most other couples. We had never explored sex toys, the world of sex toys. And we don't look at these things now as sex toys. We look at them as tools in our toolbox. And so when we did hear about your device, I was exercising, walking when I was listening to it. And before I got through with my walk, I had pulled out my credit card and ordered one of those. And then shortly after we got the tech ring in, the performance ring was made available. And in fact, one was sent to us. And so the great part about it is that once you start feeling some excitement, and guys, it will start coming back to some degree, whether we all make it back to square one or not. We don't judge it. Shirley and I don't really judge it like that. I don't know if she would agree, but we have more intimacy in our life now. We wake up just wanting to hug each other. We go to bed at night. Not that we were not loving to each other before, but when those things are taken away from you, and you know, as long as the desire is not taken away, you're going to be okay. But when we were cuddling and everything else, it's just different now, and we have fun with each other. So as far as I was ordering that device, and when I got it in, and I used it for several months, and it's like anything else. When you're not getting any visible results, you kind of put it on the shelf for a bit. And so after about 2 months, I pulled it back out and then slept in it. And it's a fairly comfortable device. You know, there's some learning curves to that. I use a little bit of our gel around the very base of my dick when I put that device on, and it just kind of seats it in for the night and adds some lubrication down there. And that's not necessary for everybody. I just found that it works for me. But after about 2 months, and I woke up and I saw, holy cow, there are some curves on this graph. And I said, I didn't even know that was happening. And so then it progressed into maybe 2 erections a night, and maybe sometimes 1 erection, and then maybe 4 and 5 erections as of here lately. So
superb.
There is some benefit in just knowing that you're improving. You may not ever make it back, like Dr. John said, to the point that you were before. But as far as I'm concerned, you know, I'm having the most fun that I've ever had in my life, sexually. And I'll let Shirley speak to it as far as, her seeing me and the instructions that she gives me now when she sees me getting excited. What's about the first thing that you say to me?
Go get your ring.
Hey, my wife says the same thing too.
And so yes, dear,
We're so easy, aren't we?
yeah, absolutely. When we're both wanting the same thing, especially.
And the doctors give us time frames that things will occur, and you've got this long after surgery, and sometimes it takes longer, and it did for us, but it has just improved and gotten better. The devices help, but the biggest thing is each time you have sex and trying to get back into it, whether one or the other one goes all the way or makes it all the way, the thing is, it's that you were there together sharing time, not that we both either got there and or one of us did. It's just there again, you've got another tool in your toolbox that basically we made an effort and we tried and we enjoyed it, and that was the important thing, not getting down about it.
What do you find? I really have to ask, how beneficial do you find the maximum performance ring sustaining your erection versus not using it?
Well, I'll put it like this. Listen, I'm not a paid advertiser. I am an avid user. I bought many tools. So I will just tell what's happened with us. And as far as the ring goes, it has literally in the last month made the difference between us being able to have penetrative sex and not being able to have penetrative sex. Now, I will say the vacuum pump always worked. I've heard people up and down on the vacuum pump. The vacuum pump has always been successful for us. So we had penetrative sex, but there is something revolutionary in your mind going on when, okay, this device will give me this, but now let's see what we can do naturally or with the aid of the PD5 medications. The performance ring allowed us to have our first natural penetrative sex in 2 years and a month, 25 months since, because we had sex the night before I went into the hospital, knowing that the facts, and we had a great time. And psychologically, I don't know how I pulled that off, but it was wonderful. And I remember that night. But that is what I thought of just a week ago when that erection, Melissa, when that 60% turned into a 80 or 85%, and then the performance ring, I call that my 15%er. And that's kind of what it did for us. And was it the hardest that I've been in 2 years and something? Well, the vacuum pump will always make you hard, but there was something natural about it. And so I do know that it's made a difference for us. And we wear the tech ring from time to time while we're having sex, just to get measurements out of that. And in the reports and the graphs that are generated, for people who don't know, you can mark your erections after you've woke up the next morning. You can mark each erection as sleeping, if that's what you were doing. If you were having sex, you say you were having sex, and that way it adds some criteria to the graphs. And so what both devices, the tech ring and the performance ring, have provided us with is confidence. And it is as sure as we get intimate with each other, whether I'm giving an injection to myself or whether I'm taking a Viagra, the words from Shirley's mouth are put a ring on it. And so as funny as it sounds, it is part of our routine, and we wouldn't know what to do, and really just wanted to thank you for making the devices available. Thank Melissa for her podcast, because otherwise we could have very well never, ever, ever found out about this device, these devices. And for people like Dr. John, who specialized in these surgeries, I mean, talking about it takes a village. It has been truly a village for us. And without Shirley, my wife of 47 years, almost here, I don't know if it would be worth it or not, but it's been so ingrained as part of our lives that missing the sexual component of it was, I don't know how to explain it other than it was psychologically damaging to me, for sure. And now when I see evidence of this coming back, it's also psychologically renewing. If that makes sense.
The surgery and the recuperation time can really take you to all kind of depths. It just depends on how you take it and how upset you get or how worried. All that stops you from being able to focus on getting well, being able to get back to sex, using the dynamics of all the tools in the toolbox. But it's patience, kindness, and belief.
Well, you're a fortunate couple to have that kind of bond, because a lot of people don't. I've recently had two people, two men with prostate cancer survivors tell me. Well, I mean, one man's experience was he had given up on sex, and he had given up on his wife. His wife had left him, and he bought the tech ring and had nocturnal erections, and he thought, well, I should start dating again, and he started masturbating, and now he's seeing someone regularly, and the ring gave him the knowledge, the knowledge that he was actually okay. I've had a couple of men recently who were giving up on the therapy, who had nocturnals, and that inspired them to continue with pumping and other aspects of the therapy.
And the one thing, Elliot, that I really wanted to mention too, you can move so far down your journey, and then you start forgetting about how you got there. Does that make sense? And Deborah Schindel, my therapist, after Dr. Borden did the surgery from Alliance Surgery in Greensboro, North Carolina, she was our coach, our mentor. She was our physio therapist, and she allowed us to be in a relaxed situation, and it was through her that I was able to acquire the vacuum erection device. And I remember telling Melissa, and I think I quoted one of her earlier guests from us, is that the first time that we used that vacuum erection device and we had penetrative sex, I told her it was like the heavens opened. And I wasn't even trying to be dramatic. It was just added a new part to your life. And then it wasn't maybe 3 or 4 weeks after that after that podcast, that we had these devices of yours to use, Elliot. And also I'll say that the customer service has been fantastic. We've had a couple of breakages, and it certainly wasn't from my size, for sure. And all that said, though, as with everything new, it comes with its challenges. But the devices that it replaced with, we haven't had any issues. Technically, I had to learn how to make sure that I wrapped the device around the charger the right way so it would charge. That was it's a man problem, we just kind of like
I'm a tech
nerd. I just couldn't get that right. 50-50 wasn't good enough. So.
I want to add that Mike's therapist, that was our mentor and everything, I wouldn't let her go. I told him he needed somebody else to be accountable to other than just me. because it was easy for him to slide or not do as many exercises or not do what the therapist asked between visits. And I said, you're going to answer to her, not just me. So, stick with them, even though you may not like it, find another way as to why you're there.
So from our hearts,
goal is.
we can't express enough appreciation for all of you. I send emails every now and then because I don't want to forget who made differences in our lives, and everywhere this journey takes me down the road, I don't have any assurances that the cancer is not going to return. No one does. But at the same time, you've provided us time in our lives that we probably wouldn't have had. So, publicly, we wanted to thank you guys as well.
Thank you.
And as a reminder to everybody out there, we both have been through cancer. I had intramedullary cancer. He had prostate cancer. So it was one after the other. Within about 4 to 5 months, we found out both of us had cancer.
So for us to both make it back through the sex journey is we consider it miraculous, but we also know that science has worked right along. Our good Lord has provided people like yourself the knowledge, and we don't want people to see these devices as taboo anymore. We're sick of that. We want to. That's the only reason we opened our lives up. The odds.
They're enhancers. They're not crutches, and so I want to talk a little bit about pumps. I never played around with a pump before, and having gotten involved in this, I was curious about them, and I found most of them to be uncomfortable, kind of weird. The reason why, at FirmTech we like the Vaxade is because it's a water-based pump, and that made it more comfortable. And we'd just like to show a short video. Riley, are you available? If you can run that video from explaining why a water-based pump is superior to a non-water-based pump.
The Vaxade pump also has some distinct benefits over the other pumps that are out there. It's the only pump designed to be used in water. When you put your penis inside a vessel that's filled with air, due to the way it compresses, doesn't necessarily compress in a uniform and even manner. The inconsistent pressure leads to inconsistent results and potentially some not so pleasant side effects such as mild bruising or blistering to the penis. The instant you change the medium from air to water, you change the compression from pneumatic compression to hydraulic compression. And hydraulics are much, much kinder to the body. The pressure inside the vessel is equal, regardless of where it is in the vessel. And so because you get the consistent, even pressure, it gives you consistent, even results. So Vaxades are medically approved in the UK, and they're prescribed by GPs in the UK for the treatment of erectile dysfunction. And they're prescribed sometimes as an alternative solution to the little blue pill and sometimes in conjunction with the little blue pill. Just to explain that a little bit further. The little blue pill will give you an erection for those men that can use it, of course. So it will give you an erection but does nothing to help with your overall male health. The Vaxade range, they're designed to be used 5 out of 7 days, and you use them as a trainer. So effectively what you're doing is you're training the penis to become erect again. You're bringing in all that fresh oxygenated blood and removing the toxins. And you may find that after prolonged use of a Vaxade pump after 2 or 3 months that you don't actually need the little blue pill to become erect again. So that's one of the subtle differences between the prescription pills and the prescription pumps. Vaxade works for 9 out of 10 users. They're the official statistics from the UK government. So anybody who's suffering with erectile dysfunction, if they use one of the Vaxade pumps, they're able to gain and maintain an erection that's suitable for penetrative sex. You should always, whenever you look at taking any form of medication or using the pumps, seek medical advice first of all. For obvious reasons, I don't know any medical conditions that you've got, so this is a very general overview of what is available and how it helps treat any of the problems you may have.
Thanks. I want to go back to Mike and Shirley for a moment too, because Mike volunteered to share some of his data with us, and Riley's going to show us in a moment just how the data showed his progress in his recovery. Riley, can you show some of those slides? So there we have some very minimal nocturnal activity early on. I don't have the dates in front of me, but here we're seeing recovery, some morning wood. Keep going, Ryle. And now we're seeing a successful sexual experience. Keep going. And now we're seeing looks like some really great sexual activity there. Mike and Shirley, way to go. And here we're seeing a great night with a lot of significant nocturnal erections, and very different from some of the flatline ones we were seeing earlier. Thanks, Riley.
Those are about 6 months apart from the flat lines to the mountains, as I call them. It was about 6 months of progress. I would say from about 12 months up till 21 and 22 months in the process.
Well, say that last one looks like mine. I'm 71 years old. I don't have prostate cancer. It looks like it could easily have been one of my readings, and that's.
I've always wanted to be like Elliot. So.
I have some questions. I want to ask John first. John, one's a question that probably won't interest our viewers very much, but I've never heard the phrase collagenization before. I'm not a surgeon. Could you explain in layman terms what collagenization is?
Yeah. So if you put your hand around your penis, most of what's inside your hand is a muscle, right? There are blood vessels in there, but the vascular spaces in the penis are surrounded by muscle. And we walk around with a flaccid penis during the day with that muscle under adrenaline control. It's contracted and the spaces are tiny, like very tight Swiss cheese spaces. That muscle has to relax to allow blood to flow in. As that blood flows in, those spaces get larger and we get elongation and girth enhancement in our penis. And that process closes off the veins that draw blood away. That's the valve mechanism. There's a natural smooth muscle collagen ratio in the penis. It's predominantly muscle. And as that muscle gets replaced by collagen, that muscle cannot relax. And therefore blood can't flow in and the valve mechanism stays open. All right, that's venous leak. Okay. So when that balance shifts away from muscle to collagen, as can occur after poor nerve sparing surgery, prostate radiation, hormone therapy, diabetes, obstructive sleep apnea, very low levels of testosterone, then you end up getting this condition called venous leak, VENOUS leak. Okay. So collagen is the pathway to permanent ED, and many of those patients don't even respond to penis injections. And even in those men, a vacuum device may struggle to work. No matter how tight the ring is, the leak may overcome that process.
If venous leak is so common, and I think, as you know from our discussions, that all men get venous leak. I almost want to call it venous leak of aging. All of our smooth muscles throughout our body, weaken with aging, but what's particularly noticeable in the penis, we get erections, but they're harder to sustain, whether we have disease or don't have disease. Why is there a resistance on the part of? Is it just ignorance, or why is there resistance on the part of surgeons, urologists, and GPs, interns, the whole medical field, to the use of rings, which I regard as a mechanical solution to venous leak?
Yeah. So I think we have to be careful about what we mean by venous leak, right? Anything that causes that muscle to stay contracted, okay, to fail to expand, technically can cause leak. In medicine, real venous leak is collagen deposition and structural changes in that muscle. High levels of adrenaline can do the same thing, so they can mimic each other. So men who come in to see us, for example, who, whatever age they are, who get a rigid erection, 80% rigid erection, I say, and as I go to penetrate, I lose it quickly. That is invariably adrenaline-mediated ED. Okay, so there is a difference between collagenization and adrenaline.
Mm-hmm.
One of the challenges with vacuum devices and rings in general is that there are 4 ways that blood leaves the penis. 2 from the penis on the top surface, they are the dorsal veins, and from the bottom surface, they're called the spongiosal veins. But there are 2 sources of outflow that sit behind, the crural and cavernosal veins. So the standard ring in many men will struggle to overcome the leak if a man has true leak. Okay. So I think that, we have yet to see, as you mentioned, Memorial Sloane Kettering will do research with the tech ring. And what we're really looking at, and Melissa alluded to this, is the ability for men to monitor their erectile function before surgery and early after surgery. And that's going to be a very important study to validate the tech ring as a meaningful contribution. There are lots of other things. Elliot and I have spoken over many months now about novel technologies that the tech ring can be used for. And it may well be at some point in time in the future that we will be able to measure oxygen content inside the penis. Rehabilitation really revolves around oxygen. And if we can give men, put in their hands a means by which they can monitor their own penile oxygenation, well, that will just revolutionize penile rehabilitation post-prostatectomy and cystectomy and rectal surgery as well. So very exciting stuff down the pike.
Well, it's hard to tell men who get an erection and lose it that yours is an untrue leak versus a true leak. But with a lot of one second, Melissa. A lot of men, I think there's some confusion about the benefit of pelvic floor exercises. Sexual function is smooth muscle function much more than it is skeletal muscle function, and I think a lot of men are being told that if they do pelvic floor exercises, that will improve their function, their erectile function after surgery if they have erectile dysfunction. What can we do to address that issue?
Are you asking me or John?
I'll ask both of you. Go ahead.
Well, in my experience, I think that doing pelvic floor exercises definitely do help with erectile function, just purely because there's more blood flow happening down there. But what I think is really important that's often overlooked, and I interviewed a young man with this issue recently with erectile dysfunction, nothing to do with prostate, but he had a really hypertonic, too tight pelvic floor. So I think we oversimplify it, that there's a lot of stuff out there in, where people can find information on the net that, I've got erectile issues, I should do lots of pelvic floor muscle exercises. And I think that can also in itself create a problem. So I just think it's really important that we need to be able to contract and relax our pelvic floor. And that's why I think it's so imperative that people get trained on that properly. You shouldn't just be going, hell for leather and getting your pelvic floor as tight as you can. So you can overdo things. So I think it's just really, really important that too tight, too weak are not going to help. We just, we need a Goldilocks pelvic floor, and people need proper training and education on how to do that. And we can't just be thinking a one size fits all for these things. And I also think that, as I alluded to earlier, that having good erectile function and sexual function is not just pelvic floor. It's not just medications. It's not just using the right pump. It's about having this holistic approach and the overall program and plan about your whole body health that improves these things. John?
I want to change the subject, go back to John for a moment. This is National Prostate Awareness Month. I'm the oldest person here. Over the course of my life, things have changed in terms of what's recommended for routine screening. And if John, and Melissa too, if both of you could comment on what you think should be the routine screening for men who are 50, 60, 70 years of age for prostate cancer.
Well, we've gone from a very paternalistic view of screening to one of shared decision-making. And I think that the screening is not just to diagnose prostate cancer. The screening is really aimed at figuring out what kind of prostate cancer you have. There are prostate cancers that are lethal, high-grade prostate cancer that has escaped the prostate before treatment. And there are prostate cancers that are never going to cause anyone to die. And that's why there's been a shift away from operating on what's called Gleason 6 cancer. In fact, there's a discussion in the cancer world whether Gleason 6 cancer is actually cancer at all. So I think that the recommendations are that, and when a man approaches 50, that a discussion be held with them about having a PSA level check. If a man has a first degree relative with prostate cancer, that be done at an earlier age, generally speaking 40, but again, all shared decision making. If the PSA is a concern, we now in the modern world have new blood tests that can start giving us more probabilities about whether that PSA represents benign enlargement or cancer. And we have MRIs. And the MRI, all that together goes into a decision-making tool about whether a biopsy should be done, a prostate should be biopsied. There's a lot of pushback about the role and value of PSA screening, the number of people who need to be screened to save one life, okay? The problem is that it includes many men who have very mild or low intermediate grade cancer. The value of screening and the value of biopsy is to define if you have life-threatening prostate cancer or not. If you don't, you may not need to be treated. In fact, there are very large active surveillance programs in many centers in the world, and people are just monitored. But there are men with Gleason 8, Gleason 9, Gleason 10 cancer who will die of their prostate cancer if it's not treated. So that is what I would consider to be state-of-the-art screening at this point in time. And finally, the digital rectal exam, where a man's prostate is examined by a physician's finger, is really starting to fall out of favor, given the role of MRI that we have now in looking at the entire prostate, and as a much greater ability to look outside the prostate.
Good to hear.
So I agree 100%. I think that screening after 50 is good, and 40 to 50 if you have a family history. The one thing that I do think, though, is I think that, and I don't know in your countries, but in Australia, I think GPs are really strapped for time. And so what happens is they are very quick to go, oh, it's raised a little bit, and then panic the man. So I think that doing prostate cancer screening is excellent, but so we don't overtreat, we need to make sure, and we don't make people really anxious. We just need to make sure that they understand that PSA is a screening tool, and it's all about how it goes up. And there's all these other things that need to be done afterwards to decide whether or not treatment's necessary, such as an MRI, such as a biopsy maybe. We're very lucky in Australia, we now have PCMA PET scanning as routine if people have a particularly high PSA. So I think that it's just really important that we educate our community that doing a PSA is like doing a pap smear or a cervical screen on a lady. It doesn't mean they've got cancer, or it doesn't mean they've got any changes in cells that need to be operated on. It just is an indication of what's going on. So I think there'd be a lot less angst and hopefully a lot less over-treatment if people were more educated about what PSA meant. And so, yeah.
Thank you. John, is there anything further you'd like to add before we wrap up?
Yeah, I think that we have an Australian on the meeting tonight. So I just want to make a plug for the Movember guidelines. So Movember, of course, is a very famous organization stemming out of Australia, which has supported the development of new guidelines on sexual health in the prostate cancer space. And there are many key, there are 47 statements, there are many messages out of that. But the one that I really want to emphasize, and this goes back to what Bill and Shirley said earlier on, is that at least in the United States of America, sex is a very linear process. Man gets aroused, he gets hard, he penetrates, he has an orgasm, and he goes to sleep, right? And there's a complete ignorance of the concept of sexual outer course. And alluding to what others have said on the call tonight, I have women who come into me with their partners, with their male partners who have prostate cancer, who will say 1 year after surgery, he's the best lover he's ever been, because it's not so penocentric. It is more about intimacy. It is more about all those things that people can do without penetration. And I think that men need to understand that there's a whole panoply of things that you can do under the umbrella of sex that are not intercourse based. And I would love to see the American man, the Western man, at least, understand that that was available to him. And the impact I talked about earlier on from Stacey Loeb's data about the very negative impact that prostate cancer therapies, diagnosis and therapies have on her And that is not appreciated by men, and it's most certainly not appreciated by the doctors who treat men with prostate cancer.
Yeah, could I just add to that? I think that is a really big part of the rehabilitation that we teach in my clinic and in my online information, is that sex is not intercourse. Sex is everything else that we do, and it's about being involved. Like, it can be solo sex, it can be out of course, it can be all of those things. And I think this is an opportunity to expand your repertoire, change the script, make things different. And I think often it can be a great thing in your sex life. And I've used this example of a couple I have that she's 10 years younger than him, and she'd always wanted to try sex toys. He was too embarrassed to go to talk. He did too, but they never mentioned it until he got prostate cancer. And now, I just had a Zoom consult with them the other day because they live in an outback station, and they're like, we're keeping adult shopping, in business nowadays. We're getting all this stuff delivered to our station and trying, and their sex life's so much better. And they are having penetrative sex again. They're using a Max Pro. I've taught them how to do injections, and they're doing that, but they're doing that less and less because our intercourse is not so important anymore. And I just think that it really can be a real opportunity to change your life and to change your intimacy. And I think as practitioners, we owe it to our patients not just to talk about getting the erection back, but to look at that whole approach to their intimate life and give them resources to look at.
I think that we as doctors are at fault for this situation. I don't mean myself personally, but our scoring systems, the erectile hardness score, the IEF, the SHIM, they focus on penetrative sex. But John, I think there is good news because our customers speak to me about their sex lives in a way that they don't feel comfortable speaking with their doctors. And I would say that it's the norm. The people that I speak with who are over the age of 50 or 60 or in committed relationships, at least, that intercourse is actually interplay. It's not interplay. It's not the be all or end all for the couple. I think the issue for men, for talking to our customers at FirmTech, is men who are dating. They feel they must perform, and I think it's a major cause of performance anxiety and failure on the part of aging men.
No doubt, and of course, men are only as good as their last erection, right? So if the last erection is bad, then they walk into the bedroom the next time with anticipatory anxiety, and that's an adrenaline-generating event, and therefore you end up getting all kinds of problems with your erectile machinery. So, but the reality is, and I'm sure this is as true in Australia as it is in the United States, and where I trained in Ireland, there is no real education in medical school of physicians about how to have a sexual discussion. In fact, many physicians avoid it, and many urologists avoid it, even though we're the penis doctors. So this is a real problem that goes back not just to physicians, but to medical students and trainees in general.
Well, that's a subject for another webinar. What questions should they ask? What questions should be in the electronic health record in Australia, the United States, the UK, that so physicians know someone comes in with a question about the sexual health. This is what I should ask. Matter of fact, I should always be asking these questions because it's so important to people's health.
Yeah, but Melissa alluded to the fact, and this is true in the United States, where primary care physicians are just so overwhelmed. There's got diabetes, obesity, cigarette smoking cessation, hypertension, dyslipidemia, and sex is number 13 on the list. And they just don't have time to do that. And so the PD5 inhibitor industry spent $1 billion trying to convince primary care physicians to be the gatekeeper in the ED world. It just doesn't work. They don't have time. Not interest necessarily, they just don't have time.
Yeah, and I think the trick there is we need to educate people to ask these questions themselves and seek out the information, which is why I personally think that trying to teach health professionals who are already busy to bring this subject up is going to be a very long process. But if we can educate our community to know the right questions to ask, then we can turn it around much quicker.
Okay, well, I'll wrap it up then. 1, make time to have sex, put a ring on it, pump it up, and get your data for your health.
And talk to your partners. And if you're single, don't worry.
And finally, if you're over the age of 40, discuss getting screened for prostate cancer with your doctor. That's critical as well too. Thank you, everyone.
Thank you.
Good night.
Well, guys, that was